To the OSPN presentation on virtual care with at the Ottawa Hospital, or TOH as we know it. It's a special presentation to OSPN, and my name is Jennifer Birch-Jones. I use the pronouns she and her, and I am delighted to join you today as a member of the Ottawa Hospital Rainbow Patient and Family Advisory Committee, a newly created committee at the hospital to advance their inclusion work. It is co-chaired by two members of our community, Tim Hutchison and Ben Murray, both of whom you probably know, and has approximately 10 to 12 members that meet every 2 months starting since September to talk about and initiate and work with the staff at TOH to advance LGBTQI2S inclusion, both on education on the part of the staff and as well as practices. So we're delighted to have this opportunity today for this conversation. Before I introduce your guest speakers, I'd like to let you know that Glenn Crawford, who is, through the OSPN, is kindly being our producer today. Glenn will be recording this webinar, and it will be posted on the OSPN page because lots of people like to access the webinar after the fact. So what we'd like to let you know is that should you wish to ensure your anonymity, we will be using the pin feature. So our guest speakers will be shown during, and the slides during the recording, but you may want to turn off your cameras or change your name should you wish not to have that inadvertently show up in the recording. We'd also ask you to put your mics on mute, and we will be encouraging questions throughout. So just fire them in the chat function, and you should see the chat function at the bottom of your screen, the little bubble. And Glenn and I will be moderating that and passing those on to Reece or Heather as we go. Okay. It is my pleasure to introduce you and turn the webinar over to Reece and Heather, who are going to talk about virtual care during the pandemic. Over to you. Reece is going to lead off.
Well, thanks so much, Jennifer, and thanks to all for this warm invite to speak today on virtual care. And as you mentioned, I'm joined by Dr. Heather Clark today, who's our medical director lead for virtual care at the hospital. I just wanted to check in to see if my slides are showing. Good? Okay.
They are. Great work.
So it's such a joy to come today to talk a little bit about something other than COVID-19, although much of what we'll be talking about has a little bit to do with our response to COVID, but certainly it's a delight to be here. And for us, it's a really exciting time for healthcare and for advancing healthcare through virtual care. So I want to thank you for the opportunity today to come and discuss what we've been doing at the Ottawa Hospital. So we did prepare a presentation and discussion today to talk a little bit about our journey at the Ottawa Hospital around virtual care adoption.
Reece, we're just seeing your desktop now.
Oh, I apologize.
There we go.
Is that good? Okay, sorry about that. We did have some objectives for our presentation today. So we wanted to talk a little bit about some of the factors that influenced virtual care adoption, both before and during COVID. We wanted to define virtual care because a lot of people are talking about virtual care generally in many ways around the system and how they're receiving it. So we wanted to talk a little bit about what we're doing here at the hospital. Wanted to show you our virtual care innovation strategy that we've been working hard on over the last year and through the pandemic. Talk a little bit about some of the benefits and challenges that we've had, and then some recommendations from a patient perspective. So a little bit about the Ottawa Hospital for those that aren't as familiar. So we are one of the largest academic and teaching hospitals in Canada. We have obviously an affiliation with the University of Ottawa Medical School, as many other learning institutions as well. We have a significant operating budget. So our budget at TOH is about $1.4 billion a year. So quite significant in terms of taxpayer support. we're a big family at the Ottawa Hospital. We have about 12,500 employees and about 2,500 physicians on any given day. So, you know, we're a large family, and certainly serving a population of about 1.2 to 1.3 million people here in the region. We also service, some of you might not know, we service other provinces as well. So we do have service line agreements with provinces like Nova Scotia, Newfoundland and Labrador. We do service populations as well in the northern part of the country, Nunavut, etc. And our current bed count at the hospital is about 1,300 beds. And that's across our 3 main campuses, which includes our major trauma center, as well as our cancer center here as well. So our vision at the hospital is pretty simple, but very powerful and impactful. It's to provide each patient with the world-class care, exceptional service and compassion that we would want for our own loved ones. And I have to say, I've had the benefit of working in a number of hospitals across the country during my career to date, and I really feel that staff, employees, and volunteers really relate to this, because it's such a simple concept to understand and relate, treating others as if they were your own loved one. So that's just to provide a little bit of context in terms of who we are, and maybe some additional information for those that weren't as familiar. In late 2019, Ontario's new Digital First for Health strategy was launched from the ministry. And they did that, from what they said, was to really change the patient experience in Ontario in healthcare. It had 5 key goals that I'll just mention here. So the first was around expanding the availability of video visits. So I think some of us may have had a personal experience with that to date, but that's certainly one of the main goals around their strategy. The second was around expanding access to online appointments. So patients being able to book their own appointments around their own availability. The third was around greater data access for patients. So patients having the opportunity to review through a secure method their own health records online, their own lab results and DI results, as an example. The fourth was around connecting tools for frontline providers. So this is a way that, you know, between providers, sometimes it's difficult to, you know, transmit information related to a particular patient. So if a patient is a patient of the Ottawa hospitals, we may not have access to information that's important from the family doctor, as an example. So this was one of the key areas that they wanted to focus on. And the last was around data integration and analytics. So this is really around, you know, understanding the population that we serve. What data do we have that we can learn a little bit more about the community and how we can better serve them. So the first phase of this strategy was to increase the availability of virtual care for patients. They did invest $3 million in new funding, and that was really to compensate physicians for video visits who signed up to pilot that. In addition to that, what they wanted to do was take a look at the legislation and some of the around personal privacy and sharing of personal information as well. And so those were really the 2 key focuses for the ministry at the time. So here at the hospital, we kind of found ourselves having the right ingredients, if you will, for virtual care adoption. The ministry, as I said, through their playbook, kind of made it clear that virtual care was, you know, a priority for the province. At TOH, we had just gone through the implementation of EPIC, our new medical record here at the hospital. And with the rollout of EPIC, I think our providers were really primed and ready to adopt virtual care. Having just gone through that investment of time and energy and planning for the new health record, we were really ready to say, okay, let's move on and let's try something new here. And of course, from our PFAC committee, we heard from our patients and families, our advisors, many stakeholder groups, that virtual care solutions was something that they wanted the hospital to move forward with. So I think all in all, we had a very good readiness to try something new. So pre-COVID, we really were starting to get our feet wet in terms of virtual care. We had thought that this would be a 5-year plan for the hospital, to be honest. And we were trying to really think about what it meant to have virtual care in TOH. So we did look at a corporate strategy. It's always been part of our mandate to provide telemedicine as an example at the hospital. So these are where patients go into another community hospital or a community access center and actually have a visit with a provider. But what that means is that the patient has to physically leave their home and go into a host site to have that video visit. And we've been doing that for over a decade at the hospital, and we continue to serve tens of thousands of patients a year through that program. But we wanted to try a home video visit program. So we partnered with the Ontario Telemedicine Network, and we started to pilot in our endocrinology clinic this idea of having patients be at home and having their virtual visits through the OTN platform. It was a very good success. We had done about 1,500 visits through that pilot. But what we found was that patients and providers had some feedback about what they said was the clunkiness of that system. So what happened was, from a practical perspective, patients had to log on to the OTN system in order to launch the visit with their provider. On the provider side, our providers had to schedule the appointment in Epic, and then they also had to schedule the appointment in the OTN system. Physicians and providers had to document in Epic as well as OTN. So it was a very inefficient way of providing virtual care. So we wanted to think about how we could do that a bit differently. So then COVID hit, and we were chugging along and learning from that pilot, and then this force of nature came about that really propelled us forward. So I think, as many of you know, virtual care has had great attention this year, given the necessary reduction of in-person visits at the hospital. I think virtual care has become a household name now to many of us. The Ontario government said in the last year, over 25% of Ontarians have had at least one virtual care encounter. And that's up from less than 1% the year before. So quite a significant jump in 12 months. So to align with that, we set out to develop a strategy for virtual care and to try to define what virtual care means to us at the hospital. So we did a little bit of soul searching. We looked across the country and actually internationally to see what other institutions were doing. And here in Canada, I'm happy to report that we were one of the first academic centers to establish a definition for what virtual care means to us. And here's what we came up with. Virtual care occurs when patients obtain advice and support to optimize health and or to manage acute or chronic medical conditions without a healthcare practitioner being physically present. So this really depicts our overarching vision, and we define it as any care that patients receive and have an interaction with a provider where the provider is not actually physically present with the patient. So patients, could therefore be at home, or they could be actually within the hospital and talking to their care provider through a video platform. They could be in a long-term care facility, as an example, or a retirement home. So the patients can really be anywhere, but it's that interaction with the provider when they're not physically present. There's certain virtual capabilities like remote monitoring of biometrics, so online tools like self-assessments and secure messaging you may have heard about. These all fall within the definition of what virtual care means to us at the Ottawa Hospital. So we really believe that when you add up all of these potentials in terms of what virtual care means, it really represents an opportunity for us to transform the way in which our patients receive care, not only at the Ottawa Hospital, but in Ontario generally. So this diagram represents our virtual care innovation strategy at the hospital, and we're quite proud of it. It's one of the first that we're aware of, and it was just actually published in the Canadian Healthcare Management Journal. It's really the work of many creative and innovative minds. We engaged internal providers and leaders to understand where we thought some of the opportunities were related to virtual care. And I'm not going to go through all of it in detail, but I just wanted to highlight for you some of the aspects of the strategy. So you'll see at the very top this notion of the quadruple aim. And the Institute for Health Improvement came up with a notion called the quadruple aim. And it's really to improve on 4 things. The first is the experience and outcomes of patients. The second is around improving the health of the population, so those that we serve generally in the region. The third is around actually trying to reduce the cost of healthcare. And the last one, which was an important add to this model, was the actual provider experience and how providers are interacting. Our strategy has 5 foundational characteristics that you'll see at the bottom, and we really thought that these were really important in order for us to move forward virtual care at the hospital. So the first was a culture of willingness. So patients and providers who are really motivated to adopt virtual care solutions. The second was organizational structure, and this is really dedicated leadership and decision-making within the hospital that have a clear operational accountability for moving forward virtual care adoption. The third is around digital innovation. So this is an internal group that we have that's really structured to build partnerships with technology companies, other hospitals, other provider centers, et cetera, to try to advance digital solutions in Canada. Engaged partners, so these are our relationships obviously internally, but also externally to support and champion virtual care adoption. So it could be the Ottawa Health Team, other hospitals as an example. And the last was this alignment with the ministry strategy. So as I mentioned at the beginning of the presentation, that those 5 sort of high-level goals that the ministry came out with last year. So with those elements in place, we did identify 8 distinct areas of healthcare where we thought that a focus on innovation around virtual care could move the mark forward. So Heather's going to talk a little bit more about one of them being health maintenance and management, but I thought I would just quickly mention that there are 7 other ones here that are equally important and that we feel will help move the mark around virtual care. So with that, I'll hand it over to Dr. Clark, and she'll talk a little bit more about our actual implementation on the ambulatory care side. Over to you, Dr. Clark.
Thank you, Reece. So I'll just give a little brief introduction. So my name is Dr. Heather Clark, and I am the medical director for ambulatory care. And as of pandemic, I became the medical director for virtual care under the auspices of working with Reece. But I am a practicing general. Oh, the presentation went away. Sorry, I'm not seeing the slide deck.
There it
but
is.
I'm a practicing general internist, and so I have the pleasure to be able to treat patients. And so I experience the implementation of virtual care from both sides, from implementation and actually from the practical side as a practicing physician. We were very well placed, I would argue. We had just purchased and implemented an Epic electronic medical record, which was a true 100% electronic record, which we did not have prior to the pandemic. And we started with this in June 2019, and we had a fair amount of growing pains with us. But it enabled us, when we had to move almost 100% to virtual care in the ambulatory care setting due to the pandemic and the restrictions placed on healthcare facilities to only provide emergent and urgent care in that first phase, that we were set with an electronic record. And again, as Reece had mentioned, we started out already having some experience with using OTN to do virtual visits, but clearly that wasn't going to meet our needs in the context of the pandemic. We provide over 1 million ambulatory care visits per year, and we would be able to see some patients emergently or urgently, but in a moment we had to pivot almost to providing all visits as a virtual care visit. So we were very lucky to have this electronic record, as well as a very engaged leadership and physician team. As well as with the ministry, they had put in place funding and billing codes to allow us to actually provide virtual care and be funded for it. And so prior to the pandemic, the only way you could do a virtual visit was through the OTN platform. And they opened this up and realized that we needed other platforms to be able to provide care. And so we were actually able to integrate Zoom into our electronic record. As well, we were also able to provide telephone visits, so you could have somebody on the phone and using the electronic record at the same time. And so we were able to provide, in the initial phases, almost 85% of our ambulatory care visits were being provided virtually, as we needed to in the first emergency measures. Obviously, we ran across all sorts of stumbling blocks and learning blocks as we were doing this, and we would never have been able to transition or get so many physicians and patients to participate in this without the pandemic. But it was a major learning process and allowed us to provide care. Reece, do you want to move to the next slide for me? And this became very slick, I would say, from the physician point of view and from the patient point of view, to actually participate in a virtual care visit. It does require some technology, and that is a challenge, and we recognize that. And that, as we move forward in future work, we'll be looking on equity of healthcare and how we're going to be able to provide services to those that are less able to access technology. You do, as a patient, require a device, whether it's a smartphone, tablet, or laptop. You do need internet access. And the way we're presenting it to the patients is they sign up for our MyChart, which gives them access to their health records. And just as an aside, this has been a huge benefit for patients, I think, that they really, really like, because they can have electronic access to all information in their health record. The provider for the appointment, it is scheduled, and within the electronic record, from a provider point of view, it's one click to start a Zoom visit, and the patient can be waiting in the waiting room. So the patient will access through the MyChart the link to go to that visit, and then you can connect. And I've used it many times now, and it is very well received, I would argue, from a patient point of view. And given that we can't see many patients in person, a video visit versus a phone, the engagement and the ability to interact with the patient is so much better with a video visit, because you can actually observe them, communicate. There's some communication as far as body language, etc., that you can have, versus this discombobulated voice over a phone. And I recognize that phone is necessary in many ways, but because many people don't have access to this technology. And that's something I think we need to look at and investigate in the future. Reece, you can go to the next slide. So to get to this point, obviously we had literally no patients, no physicians that were actually doing virtual visits. So in a matter of weeks, we onboarded, which means from our providers, they received instructions on how to provide virtual care. It had to go from division by division, and they had to have instructions on scheduling, etc. And from a patient point of view, there was a lot of information that had to go out. We created videos for the patients on how to observe, how they would proceed with a virtual visit, etc. So we had provider videos, patient videos, instruction sheets, tip sheets, etc. You can go to the next slide, Reece. So this is just a graph, a very simple graph, and I'll walk you through the numbers, but on the y-axis, that's just the number of visits by visit type. So, and then along the x-axis, you can see those are the dates. And so really the very start at January, February, you can see there was almost obviously no phone visits, very few virtual video visits, which is the blue line. So that was basically our OTN pilots. And then the pandemic hit, and within an instant, we went up to almost 25,000 phone visits per month that we were doing. And as far as the video visits, it quickly swept up to about 5,000 video visits through the organization. And that has stayed fairly steady. The phone visits have started to come down a little, I think. And then what was happening there is, as things were opening up again, there was the opportunity to see some patients more in person. You can proceed to the next slide. We did do some initial surveying, and we have more data on this. So we actually started with a patient satisfaction survey, and really it wasn't so much for the quality of care. We were trying to address from the patient's point of view their ability to use the technology, how the visit went, and would they want to have another virtual visit again. So this is preliminary data, but even after we're up to about 1,500 responses now, and the data stays pretty stable here. Most people report no problems with accessing and don't require technical help beyond the tip sheet. If there's a problem, it's often with the audio, and I don't know how many of you do Zoom calls or do other virtual meetings, and I must admit that's always, if there's going to be a problem with the Wi-Fi, it does seem to be the audio content. Very few people express concerns with the privacy or confidentiality of their medical information. And again, from a practical point of view, as a physician, when we're doing this, we would always be telling people about the risks and benefits of doing a call virtually. And usually you would also make sure that the patient is able to be in a confidential and quiet space. So there's a bit of a little introduction at the beginning of a virtual visit to ensure that the patient's in an area where they can speak confidentially. And then also as a physician, I would say I'm in an area or space where I can be able to communicate with them. The vast majority of patients said that they do understand what was the next steps, which is important for their medical care. And most patients said they would choose a virtual visit. We have a little more data on that now, which says, in fact, we're starting to see most people state they would like an in-person visit first. So if they've never met the physician, they might appreciate an in-person visit the first time, but for follow-up care and management, the vast majority of people prefer a virtual, or would agree to a virtual visit if offered at the next visit. And you can go to the next slide. And these are just some of the advantages that we've really found and what we've also heard from patients in their comments section. It is a pandemic, so most people are working at home, so it's super convenient. They don't have to travel. The biggest complaint we've always had for ambulatory care at the hospital is parking. So not even the getting a spot, but it's, it's the cost of the parking and then even finding a parking spot. I know at the Civic, it's crazy. If you're trying to get in to see somebody, you could be late for your appointments. The big thing that I think really struck us as healthcare providers is what that risk was actually coming to the hospital. So we were really able to provide safe care for our patients, minimizing their risk, keeping social distancing, and also minimizing risk for our healthcare providers. And initially, we were obviously in the start of the pandemic super concerned about the access to PPE. So there was really a big concern about preserving PPE. So the more virtual visits we were providing, the more we knew we were keeping our patient population safe, as well as our physicians. Again, from a patient point of view, there's access issues, mobility, paratranspo, again, getting to appointments can be extremely difficult for many patients, and so virtual care can be helpful. I would argue as well, initially patients and physicians raised the concern for those that might have cognitive issues, language, translation, etc. And we've become even more facile at doing three-way calls. So if you're on a call with your mother, you could actually be zoomed in and linked into a three-way call with the physician. So it's worked really well at conferencing for complex patients. We've been able to do that with interpreters as well. And as well, many places are starting to do environmental studies and just by postal code analysis where patients are living, start to do an estimate of the kilometers saved on travel by doing virtual visits versus coming to the hospital. And I do find that really interesting because as a general internist, we do provide care through patients throughout the region. And I would invariably always have patients coming from Barry's Bay or Golden Lake, Pembroke, coming all the way to see me, and you'd be astounded that they've driven over 2 hours for this 10-minute appointment. So I think there is definitely an advantage for many patients who do have distance to receive much of their care virtually. You can go to the next slide. So I guess the question is where do we go now? And so part of what we're trying to look at are a couple of things. I think we're thinking now we need to look at who's the right patient to see virtually versus in person. There's obviously concerns on those that need physical examination. Maybe there might be concerns about communication. So there's, and if you don't know the patient, so that first visit. So I think we're starting to try to think forward on coming up with guidelines on who should be seen in person and which patients and conditions or types of visits can be done in a virtual fashion. We're also going to be looking at more trying to get at the quality of the interaction. So trying to look at the quality of care. So is it meeting the patient's needs? Is it providing good value care to the patient? And are medical recommendations being made that are important to that patient? So none of us think we'll go back to the way it is. I think from a physician point of view, many people recognize the distinct parts of their practice where the care could be provided virtually. And from a patient point of view, I hear anecdotally from many physicians that they'll say their patients say, well, I don't want to come in. Why can't I do this by phone call? Do I need to come in to do that? So there's going to be that balance of what actually needs to be an in-person visit and how much can we do virtually. And the big thing going back is that the ministry has not finalized, I guess, their digital health strategy. We believe that patients are going to demand that virtual care is there. So I don't think they'll be allowed to go back to not funding virtual care. So I think the question is, how will it be funded going forward? And I think both Reece and I are open to any questions that anybody has.
Thank you very much, Dr. Clark and Reece, for that presentation. I learned a few things. I have a question. I'll open it up to my colleagues as well. But remind me again what ambulatory care is. I know it's quite wide ranging, but it was a great definition of virtual care. But you have to remind me about what ambulatory care is.
I can take that, Reece, and I do laugh because I would say that to my kids that I'm the medical director of ambulatory care, and they think I'm in charge of ambulance.
Exactly.
So it is funny in medicine how certain things are described. So ambulatory comes from ambulation, which is walking. And so it's been the traditional way of saying this is a walk-in visit, but they're scheduled. So they're essentially all the visits at the hospital that are clinic appointments. And so this includes every visit. And that's why there's so many that are under the ambulatory service line. So if you are seeing your cardiologist, if you're seeing an orthopedic surgeon, if you're seeing a nephrologist, all of those count as ambulatory visits.
Perfect. I thought so, but I just wanted to double check. And of course, I'm going to put on my evaluation hat. And I love the fact that you're doing evaluation of the patient experience in terms of their the technology. And I know you're going to look at outcomes, right? So doing some kind of comparative analysis of patient outcomes through, in the past that were done in person that are now being done virtually.
Yeah. I think that's an excellent point, Jennifer. And to be honest, it's something that across the country our colleagues are grappling with as well. Like it's very early days for virtual care when you think about the history of medicine, hundreds years, et cetera. Virtual care is very quite new. So how do we evaluate that? So obviously we wanted to start with the patient experience overall, but your point around, so what are the health outcomes specifically, and have we moved the mark? And certainly have we made things worse? Like we don't want to do that. So so that's really the focus of the work moving forward. I'll say we did have a pilot project. We didn't mention it here because it's not an ambulatory, but it's on the inpatient side, where patients who came in for a surgical procedure, instead of staying in the hospital for, let's say, 5 days, they stayed for 2 or 3 and then went home with some devices where they could connect and communicate with their provider and team. And that study will be coming out soon in a medical journal, but it's very promising in terms of the fact that, outcomes not only perhaps were the same, but on some indications they were actually better. So you think about like infection rates as an example. If folks are away from that, as Heather's pointed out, that could be helpful too. So yeah, it's a very interesting point.
Thank you. Excellent. And George has said in the chat, what would be really great is that my file with my family physician at the U of O Health Services could be integrated with my chart, so everything is in one place. Any hope that it will happen going forward?
Yeah, so it's our vision that everyone will be on Epic, I'll say. That's going to take some time for us to get to, but the work of the Ottawa Health team has really helped to start to, that discussion and to move us in that direction. We are piloting it, I'll say, at the Ottawa Hospital through the Ottawa Family Health team that we have at the hospital. So the TOH Family Health team is now on Epic. And for those of you who aren't familiar, it's a physician practice from a primary care perspective. And we're looking to evaluate that because we do think, to your point, George, that's a really important part for providers to be able to see the information and communicate. So it's looking good, but we're trying to use the Ottawa Health team now to really propel that work forward.
Excellent. Thank you. Any other questions or comments from our colleagues? And I was remiss in not introducing Claudia Hempel, who is the staff support at the Ottawa Hospital for our a number of committees, but the Rainbow Patient and Family Advisory Committee. So thank you, Claudia, for all your ongoing support and helping to make this webinar happen as well.
It was a great webinar, and thank you for inviting us in from the hospital. And I hope it's the beginning of a good relationship, and we continue to connect once in a while.
Super. The other item I might mention to our colleagues from OSPM, those of you attending this webinar and those who are listening afterwards, is the Ottawa Hospital wants feedback on the quality of the services that they provide. Particularly, we're interested in the Rainbow Patient and Family Advisory Committee, your experiences as someone who is sexually or gender diverse. So good experiences, maybe not so good experiences. We need to hear those because the staff at the hospital are committed to learning and doing better. So where there's problems identified. So there is mechanisms, just you can get in touch with us, but I'm thinking, you know, I'll talk to Tim and Ben and make sure that there are mechanisms by which you can reach out to any member of the committee to let us know in confidence if you have a story to share, positive or something that we can learn from. So thank you for that. I am going to, if there aren't any more questions or comments, I'm going to thank both Reece and Dr. Heather Clark very much for their time. I personally am excited to be a part of the Ottawa Hospital family and and learning some more today about virtual care and where it may go in the future. So thank you. I know over the last year, you know, you are essential care workers and providers. I can't imagine, Heather, what your days have been like trying to pivot in the early parts of the pandemic. So, and Reece as well. So thank you so much for all that you do. And we look forward to hearing more about this exciting strategy.
Yeah, thank you, Jennifer, and thanks for the warm invite. We really do appreciate it. And as Claudia said, we really welcome the opportunity to come back in some time to hopefully tell you how much more we're doing as well around this. So thanks so much.
That's great. And a big thank you to Glenn for producing this and making sure that it is available to our OSPN colleagues. So stay safe, be well. And I don't know about you, but I'm sure looking forward to the spring. So take care all. Thanks again.
Bye.
Bye-bye.
Bye. Thank you again.